All right, let's dive right into this explainer. Today, we're going to uncover exactly how Parkinson's disease impacts human movement by really zooming into the chemical balances of the brain. The human body in motion is an absolute marvel of biological engineering. But we have to ask, what happens when that central control system just begins to slowly break down?
Here's a quick look at our roadmap for today. We'll be moving from the physical symptoms, through the brain circuitry, down to the substantia nigra, the resulting chemical imbalance, and we'll wrap up with pharmacological movement restoration.
So let's kick things off with Section 1, the symptoms of Parkinson's disease. To truly grasp the science here, we first need to look at the physical reality of this condition. And it's incredibly prevalent, affecting about 1 in 100 individuals over the age of 65. Parkinsonism is a progressive neurological disorder of muscle movement, and it's really defined by a few specific physical characteristics. We're talking about tremors, muscular rigidity, postural abnormalities, and pretty noticeable changes in a person's gait, or how they walk.
Now, there is a particularly interesting medical term I want to highlight here, and that's bradykinesia. Basically, this translates to a severe slowness in initiating and carrying out voluntary movements. It perfectly encapsulates the frustrating reality of what these patients experience every day. Because it isn't just about a loss of muscle strength, it's actually a fundamental breakdown in the nervous system's ability to seamlessly command the body to move when the person wants it to.
Moving right along to Section 2, brain circuitry and neurotransmission. To understand why those debilitating symptoms happen, we really need to map out how the brain commands the body. Think of normal motor control as a highly delicate seesaw, a perfectly balanced seesaw really, inside the central nervous system. On one side, we have excitatory pathways. These use neurotransmitters like acetylcholine as a spark, literally stimulating neurons to fire and command movement. On the exact opposite side, we have inhibitory pathways, which heavily rely on dopamine and GABA to cool things off and dial that activity right back down. Every single smooth movement you make is the result of this rapid, perfect summation of excitatory and inhibitory signals.
Which brings us to Section 3, the substantia nigra breakdown.
So, the crucial question is, where does this beautiful balance actually fall apart in a Parkinson's patient? Well, deep in the brain is a tiny region called the substantia nigra. The dopaminergic neurons originating here project outward, making thousands of synaptic contacts within the neostriatum. And these neurons are fascinating because they don't just fire reactively. They constantly release inhibitory dopamine to provide a steady, tonic, sustaining influence on our motor activity. They are essentially the smooth operators of our central nervous system.
And this right here brilliantly illustrates the silent severity of the disease. Visible movement symptoms, like a hand tremor, only begin to appear when a staggering 80% of these vital dopaminergic neurons have already been destroyed, leaving just 20% behind to do all the heavy lifting. The brain has this incredible reserve capacity, sure, but by the time a tremor is visible to the naked eye, the microscopic damage is already profound.
Let's unpack that further in Section 4, the chemical imbalance. Let's look at how this microscopic breakdown physically translates into the loss of movement we just talked about. With those dopamine-producing cells dying off, the brain basically loses its brakes, its inhibitory influence. So while the calming dopamine is greatly diminished, the excitatory acetylcholine remains at normal levels, leaving it relatively overactive.
Without that dopamine to keep things in check, our seesaw slams completely over toward excitation. This massive overactivity of acetylcholine triggers a chain reaction of abnormal signaling throughout the basal ganglia. And the end result? A profound loss of muscle control, physically manifesting as those resting tremors, the rigid muscles, and that slow bradykinesia we outlined at the start. Knowing the root cause is a dopamine shortage, medical science is faced with an absolutely massive challenge. How on earth can we chemically correct this microscopic balance? Like, how do we actually put dopamine back into a degenerating brain?
And that leads us to our final stop, Section 5, pharmacological movement restoration.
The primary strategy here is to use pharmacology to trick the body, restore those dopamine levels, and fix the chemical imbalance. And it's brilliantly achieved with a tag team of drugs. You see, you actually can't just give a patient a dopamine pill. Well, you could, but it wouldn't work because it doesn't cross the blood-brain barrier. So, step 1, we use levodopa, a precursor that actively transports right into the central nervous system. Step 2, a drug called carbidopa is administered alongside it as a shield. Carbidopa intentionally stays in the peripheral body to guard the levodopa against early metabolism. Then, step 3, the surviving levodopa safely reaches the brain where that remaining 20% of residual neurons converts it into fresh dopamine.
By using carbidopa as that bodyguard to prevent the premature breakdown of levodopa in the gut and peripheral tissues, the required therapeutic dose of levodopa drops massively, by 4 to 5 times. This is a total game changer because lowering the dose by that much prevents severe, debilitating side effects like intense nausea, vomiting, and dangerous cardiac arrhythmias.
But there is a catch. As the disease inevitably progresses, there are fewer and fewer cells in the substantia nigra capable of converting that levodopa into dopamine, so patients begin to experience severe motor fluctuations. The relief provided by these drugs is only symptomatic, and it only lasts while the drug is actively circulating in the body. When the drug wears off, patients experience what's known as the on-off phenomenon, literally suddenly losing normal mobility, experiencing cramps, and just freezing up completely.
To counteract this awful wearing-off effect, pharmacology provides a few more tools for the toolbox to extend the drug's lifespan. COMT inhibitors like entacapone are added to block peripheral competition, making sure more levodopa actually makes it into the brain. Simultaneously, MAO-B inhibitors like selagine are used to decrease dopamine metabolism directly inside the brain itself. Working together, these drugs stop the body from chewing up the dopamine too quickly, effectively extending the critical window of time a patient can walk and move normally.
Now, when those motor fluctuations just become too severe to manage, doctors can turn to dopamine agonists like ropinirole, pramipexole, rotagotine, and apomorphine. These are really cool because they completely bypass the need for that cellular conversion step. They just directly stimulate the brain's dopamine receptors, which often provides a much longer duration of action and helps smooth out those unpredictable fluctuations in a patient's movement.
But here's the thing we have to remember. While these drugs masterfully balance the scales of acetylcholine and dopamine to restore movement for a time, they offer only temporary, symptomatic relief. They do not arrest or reverse the underlying cell death that's actually occurring in the brain. It really leaves us to wonder, as we continue to unlock the complex secrets of our neurochemistry, when will medical science finally find a way to halt this debilitating disease right at its root?